So, Jonathan, they had the late-breaking trials this morning at EHRA. There was a focus on devices, which we're both very interested in from a research and clinical point of view. There were 5 very interesting studies. So the first one was raised CRT. So what did you think of that study then?
So it's a very exciting few days in Lisbon.
Yeah.
This morning started off with Michael Glickson, a team from Israel. They did a study looking at comparing speckle tracking to guide LV lead placement for CRT, so kind of targeted placement, versus the conventional treatment, i.e. X-ray, and where one thinks the best lead is. And they had, I think it looked like a 2-to-1 randomization, so they had about 100 in the image guidance arm and 50 in their control arm. And they used, of course, the speckle tracking using echo. So similar work that has previously been published by a variety of authors, including Target and other similar studies that have set the premise for this.
Yeah.
And I think the headline that was presented was that they didn't show any significant difference in their endpoint in change in end systolic volume ejection fraction.
Yeah, that's interesting, isn't it? So I think that was a little bit different to Target and Starter, which was what they mentioned in the discussion afterwards. Yeah. I think Paco Leva was the discussant, and he mentioned in particular the importance of avoiding scar as sort of the main aim for LV lead implantation.
I guess it's kind of interesting because each study in itself has tried to take one element. So we'll come on and talk about RADI in a second, and the other Danish study, but they all take one element of a factor that's important, whether it's a hemodynamics or electrical or mechanical. And I think one of the difficulties is, and you'll know this as well, as an implanter, is that each patient is very heterogeneous.
Yeah.
And so you might try to measure one thing like speckle tracking, but it won't necessarily tell you everything you need to know about viability.
Yeah.
And I think one of the other things that Prof. Leva touched on, as did the lead author, was that they couldn't get a lead into the target location in, I think, just over 40% of the time. And for me, that highlights one of the big issues with CRT in 2019, which is you might want to go somewhere, but if there's no vein there, you can't.
It's often the elephant in the room with these studies, isn't it? It's all very well saying you want to try and stick the lead in position X, but if you can't get your lead there, then it's irrelevant, really, isn't it?
Yeah, and I think that's probably, that needs more discussion, I think, because it's not that easy. You know how difficult the veins can be to get into.
Yeah.
And I think it was a very interesting study. What else was there this morning? So
I think that study very nicely segued into another study which looked at electrical versus image-guided placement of an LV lead. So from an electrical point of view, the authors looked at QLV measurements in different veins and also looked at echo measurements. And they found that using electrical markers led to a greater improvement in left ventricular ejection fraction. Yeah. But when they adjusted for a number of factors, they found that significance disappeared. It would be interesting to see the paper and what they adjusted for and how they adjusted.
So what do you think? What do you think? You have a feel for what might be different, or you think it might just be the demographics?
Very hard to say from the slides we saw. But I mean, it was only a very marginal improvement in left ventricular ejection fraction. And interestingly, in the discussion, it was mentioned that that's a slightly atypical echo outcome to use for these CRT studies. And the convention is to use left ventricular volumes, isn't it? And they didn't do that, which is very interesting.
And I guess, like you say, is echo. We all use echo in daily practice, but it's often worth mentioning that a measurement of echo ejection fraction on one day, one operator, could be up to 5-10% difference to another, and so that has a big bearing on
reproducibility of echo measurements is huge, absolutely.
Hence why prospect and things like that were probably negative on the original studies that were done.
Yeah, and I guess the other thing with electrical measurements is now we have so many more options with quadrupolar leads. I mean, you can check the QLV from 4 different poles in one vein, and it kind of almost makes some of these studies a little bit redundant, because when you have so many options with one good lead in one vein, do you really need to go and hunt around for others? I think it'll be interesting to see. I don't think the study was done with the quadrupolar lead, it was done with the standard
So do you think, so I guess that's the other question is, because most of us nowadays, I guess 2019, most people will use a quadrupole lead, assuming they can get a lead into the target, get good parameters. So do you think that if everyone switched to quadrupole leads universally, do you think that would negate any of the benefit from these image guidance studies, or do you think there's still room for manoeuvre to get it better?
I think detecting the difference and detecting the added value will be hard, because I think the studies will need to be huge.
Yeah.
Because
thousands of patients potentially.
I think getting your left ventricular lead in a good lateral branch with capture in the right patients will give you a huge benefit in a patient with heart failure and left bundle branch block. And any additional benefit from tweaking that, you're going to need a very big study to demonstrate the additional benefit.
And that, I mean, that's not even touching on the effects of AV delay. You did a lot of work on that during your PhD. VV delay.
Yeah, and I looked at acute hemodynamics, which very nicely takes us into CRT, which was the third study. And this was an interesting one because you worked very closely with the group who designed the protocol. So you're probably best to tell us a bit more about that.
So really a hell of a lot of work, like all studies, to get ready to presentation today. So Afzal Sohaib and Aldo Rinaldi, lead investigators for that. Multi-centre, international, most sites in the UK, some in Italy, and looked at over 280 patients, randomised in a one-to-one fashion. And the premise was really from the original depiction of CRT over 20 years ago by the grandfathers who brought us CRT, as it were, the hemodynamic stroke volume, capillary wedge pressure, changes in all of those hemodynamics that we know are beneficial. Does measuring that and having a lead in the vein where you get the best hemodynamic measurement, does that actually make a difference? And so that it involved a randomisation whereby half the patients had a high fidelity wire placed in the left ventricle. So it was a retrograde aortic approach, so there was an extra arterial puncture. And you would measure acutely the DPDT, so the pressure change over time when you were pacing, and selecting each vein that you could potentially go into by the hemodynamics. And essentially the headline from that was that there was an absolute risk reduction, an absolute change in the endpoint, which was end-systolic volume of 13%, and so that was really impressive, and I think a significant change. From what we've seen previously.
Exactly, and I don't think, as you say, we haven't really had an outcome study which has shown the benefits of selecting any left ventricular lead parameter using hemodynamics. So I think this is potentially quite a game-changing study in terms of how we think about CRT.
How'd you take it forward?
I think in terms of its clinical implications, I think Professor Leclerc highlighted the challenges. It'll add another €800 to the cost of each procedure. It'll extend your procedure duration time, and it may not be suitable for a lot of centres around the world. For me, that's almost less interesting. I think the practicalities of using it day to day to place an LV lead are probably not that important. I think it's more the principle really, which I thought was quite important, that it shows that your acute hemodynamics can predict how well your CRT will work down the line in the future. And I think that has a lot of implications for how we do CRT research, which is very hard. I mean, doing an outcome trial with CRT, to show any additional benefit beyond sticking an LV lead in a lateral branch, will need a massive trial. So it's a great kind of surrogate to show which avenues might be worth exploring.
And I should clarify, when I was talking about volume before, it was the difference in absolute echo remodeling. So it was a dichotomous variable rather than a continuous one, which is one of the things that Prof. Leclerc touched on. But it's
it's 14 or whatever, rather than 15%.
It's one of the problems there. You have to pick an endpoint, and I think you have to stick to it and adjust your stats accordingly. And that's the nature.
Yeah, well, I mean, they use something which has been used very commonly in a lot of CRT studies.
Absolutely.
I don't think I can really argue with that.
No, I think more CRT MPP. All the other ones have used that as well. So I think that's a fair enough endpoint to use. So what other ones were there?
So there were two other studies. So there was another remote monitoring study. This was from a single centre in Poland where they looked at remote monitoring and outcomes in heart failure. I think just over 500 patients in each arm.
It's an impressive number.
Yeah, and they found that Heart failure hospitalizations were reduced with remote monitoring, but there was no significant difference in mortality. Martin Cowie commented on it. He's got a huge amount of experience in this area. He was on the RMHF study, and he commended the authors on designing and running such a big trial, but obviously highlighted some of the difficulties. It's one country, one health system, one centre.
So how does that apply?
How does that apply around the world? But I think there's a lot to be said about remote monitoring. I think as we've gained experience, maybe we'll see the benefits more now. RMHF was negative a few years back, so it's another step forward.
But in practical terms, though, day-to-day practice, busy physiologists, how there's so much data, and that's what worries me. Is how do you assimilate that data and filter out the junk and take the information that's useful in a time-efficient manner?
We need to get it right because reducing hospital visits is such an important part of everyone's healthcare agenda, isn't it? And this seems like an easy win. Demonstrating that easy win isn't as easy as we would like.
Okay, and so we come on to last study.
So Bruce Wilcoff flew in.
Just flown in, literally.
Flew in and walked into the lecture theatre and talked about RAPIT, which showed that the Tyrex pouch reduces your risk of a device infection from 1.2% in the control arm to 0.7% in the treatment arm. So in terms of relative risk reduction, that looks pretty huge.
That's quite big.
But the infection rates in both arms are pretty low. And the pouch isn't cheap.
How much is it?
I'm not sure, to be honest.
So I think I heard kind of 600, 800. I mean, a fair amount of money, similar to a Raddy wire.
But then saying that, the costs of a device infection and the implications of a device infection, certainly in some patients,
tens of thousands.
We've seen a few really complex patients over the years who've had device infections, and anything to avoid it.
Yeah, I mean the clinical cost as well for the patient and the hospital, but also the absolute cost. Will it reduce it enough? That's the question. What's the number needed to treat?
And would you use it in a standard, relatively low risk patient? What's the added value in that? I think group the number, when the infection rates are going to be relatively low anyway.
So I think most of the contemporary data, including that from Barts where we both work, is very, very low infection rates. And so the question is, who would you use it in? And I think certainly patients having redos, patients with previous infections, that I think for sure. But for everyone, I think it's a difficult ask. It's a lot of money, and the number needed to treat, I think, is still going to remain very high.
So it was an interesting late breaker, isn't it? I think big step changes in device therapy, we're not seeing them very frequently, but I think there were quite a few little things in there today, weren't there, which kind of furthered our understanding and may change our practice. Not by huge amounts, but
small incremental
steps.
And there's going to be some more changes because I think there's some more studies out there looking particularly at image guidance, which is an area of interest of mine, and it's going to focus on looking at the tissue characteristics and whether we can guide via image guidance. But we kind of come back to that point that we raised at the beginning, which is if you can't get the lead there, then it's tough. So maybe there's alternative methods for pacing, like endocardial pacing. That's probably something to watch out.
Pacing as well.
Neither
of those things are particularly featured this morning, but I'm sure we'll see that in coming congresses.
Yeah, look forward to seeing it.
Excellent.
Cool. Thank you very much.
Thanks.